pleasure of introducing Christine. Christine has worked closely with the BC Centre of Excellence for Women's Health on a number of projects over the last 6 years, including as a provincial training consultant for a large FASD prevention and health promotion initiative called Act Now BC, Healthy Choices in Pregnancy. She's passionate about improving the health of women, recognizing the interconnections between substance abuse, mental health, and trauma, and in integrating motivational interviewing into current practices to support health-related changes. Christine is also a member of the International Motivational Interviewing Network of Trainers and has published a number of articles such as Motivational Interviewing, Women's Health, and FASD Prevention. She's also the co-founder of Change Talk Associates. She designs and delivers training for health and social services across Canada on effective communication methods that support change. We truly are glad that she's come from BC to join us in Alberta, and I'll now welcome Christine. Thank you.
Good morning, everyone. This is one of the larger rooms I've presented to without being able to see people, so it's quite an interesting experience, and really appreciating everyone taking the time to spend some time on this important topic today. And in terms of our time together, the hope is that we'll spend about the first half hour talking about some of the theoretical foundational aspects of it, and the majority of the time we'll be talking more about the how. How do we have these important conversations? So as we prepare to begin, grounding immediately in a couple of statements that you might hear from some of the women that you're having conversations with, and imagining what might you say next. So a woman says, you know, now that I'm pregnant, I've been trying to cut down, but it's just so hard when all of my friends drink. Think to yourself, maybe even write, what would you say next? Another possible comment that you might hear, I stay away from the hard stuff, which I know is bad for the baby. I just have a beer cooler every once in a while. Again, what might you say next? And I really encourage you over these next couple of hours to be as engaged as possible in terms of writing responses, thinking critically, reflecting on some of the questions that I ask, and really participating in this experience. So in terms of our time together, wanting to make this as practical as possible, and of course in terms of skill development, it's critical to be able to have not only an opportunity to hear about it, but to be able to practice it. So thinking of this as a kind of a first step in and connecting it with what you're already doing, what's already working well. And so in terms of the hopes for this time together, looking at some skills for supporting engagement and guiding principles for the conversation, how to raise the topic and a strategy for collaboratively setting the agenda. How do you get that conversation started? How to share information about alcohol and pregnancy in a trauma-informed way so that it's not powering over women. And throughout the 2 hours, I will include some questions for self-reflection as you work to integrate this information into your current practice. So the flow of our time, as I mentioned, spending some time talking about the context, integrated framework, and my skills and strategies, and moving forward. And as always, taking what you want and leaving the rest, and thinking about how this fits in with what you're already doing. So as we go through our time, thinking about who you're having conversations with, the types of conversations, where these conversations might be happening. There's no one woman that this conversation happens with. So Susan, she's 34. She wasn't planning on getting pregnant, but it happened. Her fiance is excited, but she's not so sure how a baby's going to fit in with her career. She tries to manage her stress by going to yoga 3 times a week and a glass or 2 of wine at night to wind down from the day. That might be one woman. Dawn, she's 21. She really wants to have a healthy baby, and she knows that drinking alcohol while pregnant isn't a good idea. She already knows that. And so with the help of her worker at the Friendship Center, she's managed to make some big changes and hasn't binged in over a month. Each day is a struggle not to drink. Many of her family members and her partner have alcohol problems. And Kim, she's 16. She went to a party last weekend and drank so much she can't remember most of the night. She does know that she had sex, although she didn't really want to. She isn't on birth control, and she's worried she might be pregnant. So each of these women, different context, You want to be having the conversation about alcohol and pregnancy with all of them, and it may sound a bit different. And so part of this is also thinking that there's no formula. There's no you say this and then this and then this. It's more about how do you have this conversation in an informal style that it focuses on the relationship. And so that's the emphasis of my presentation, is a more informal, relationship-focused way of approaching this conversation. The information that I share will also build on some of the previous presentations that are part of the FASD Learning Series. And so really encourage you to access those presentations on the website. There's ones on prevention. My colleague Nancy Poole recently did one in the earlier part of this year on trauma-informed approaches with women. So really encourage you to also look at those presentations as they continue to build. And putting this in the context of overall FASD prevention. So I would imagine that these documents are familiar to many of you who are already doing this work, and if not, I would encourage you to access them. And so looking at the 4-level model that was published by the Public Health Agency of Canada, and also another example that at the BC Centre of Excellence for Women's Health that they put together as well. And so in terms of where this presentation fits in the 4 levels, for the most part, it's at level 2. It's the brief conversations, the brief intervention, the conversations that we hope are happening with all women of childbearing years, and really expanding our understanding of prevention to include pre, during, and postpartum. And another variation, as I mentioned, the continuum of care model for First Nations and Inuit women with substance use concerns that Nancy Poole led and worked with a number of people from across Canada to put this model together as well. And these resources can be accessed. You have the web links for that material. And so the continuum of support, I know that given we have over 400 people online, that we have a range of places that people are working, the roles that you're in, etc. And so thinking about these conversations with women can be happening everywhere. It may be in a professional context, a peer, a mentoring context. It may also even be in a personal context. Who in your life might you have this conversation with? And so this is just an example. Nancy Poole and I put this together out of our work with the Act Now BC Healthy Choices in Pregnancy Initiative, where we traveled the province for a couple of years, went to over 45 communities, and we encouraged anyone that was working with women in childbearing years, come to the session. And we talked about some of the foundational approaches and some of the skills and how you might have this conversation. And this is just a snapshot of the range of people that we would have in the room at one time. Just fascinating work, interesting people that are all passionate about FASD prevention. So from youth support workers, family workers, key workers, midwives, dental hygienists, across the board, anyone who's having these conversations. And so I just want to continue to build the case. It's certainly preaching to the converted already. You've already shown up today. This is an important issue for you. You set the time aside. And just to reiterate why this is such an important conversation when we look at alcohol use for women in the childbearing years. So 15% of young women 18 to 19, 11% of women 20 to 24 years reported heavy frequent drinking. Women of the highest income were more likely to be drinkers, and women of the highest income were more likely to drink 1 to 3 times a week. So they may not be binge drinking necessarily, but are drinking more frequently. Women with a university degree had almost twice the odds of current drinking than those who had not completed high school. So also thinking about our own stereotypes and our perceptions of who is drinking alcohol, who may have some concerns. Alcohol use in pregnancy from the Canadian Maternity Experiences Survey. 10.5% reported consuming alcohol during pregnancy. Now previous reports have noted up to 14%. This is a newer statistic. And binge drinking reported by 11% of women before they knew they were pregnant. So this is also an important reason that we need to be talking about the preconception period as women are preparing themselves and thinking about having a child, that the majority of pregnancies are unplanned. And this is an older statistic, but important to know from the Aboriginal Peoples Survey that drinking alcohol is less common among Aboriginal than non-Aboriginal women. However, binge drinking is more common. And so thinking about there's no one woman. It's across the board. Women use alcohol in different ways. And so this conversation needs to be happening with all women. And this is from a report from SAMHSA in the US in 2009. They noted that 19% of women use alcohol in their first trimester, again, oftentimes not knowing that they were pregnant, 7.8 in their second trimester, and 6.2 in their third trimester. And of the women in their first trimester, 8% binge drink, 21.8 smoke cigarettes, and 4.6 use marijuana. So also highlighting the interconnections of other substances as well and how those are linked. Now, important to note when we're thinking about postpartum and ongoing prevention for the next child as well, and wanting to help a woman maintain the health improvements that she's made, is looking at the statistics around rapid resumption, is what they called it, of substance use noted in the first 3 months postpartum. So although women may have been able to make changes during that time, looking at the postpartum statistics. So in alcohol from the third trimester to 3 months postpartum, you see it jump back up to 31.9% use. Binge drinking of concern there in third trimester, 1%, 3 months postpartum, 10% of the women, the rapid resumption to binge drinking. And you can see with cigarettes also the tremendous increases again postpartum. So we need to be stretching this conversation across the span. And the health impacts for women. Women and men are not created equal when it comes to the impacts of substances on our bodies. Women are more likely than men to develop cirrhosis after consuming lower levels of alcohol over a shorter period of time. The phrase that's often used is that women have a telescoped course, so they get sicker quicker in many ways. Heavy alcohol use has been found to significantly contribute to the development of osteoporosis, breast cancer, reproductive problems, heart disease, stroke, alcohol-induced brain damage, just to name a few. And some of you may be familiar, and others, this might be new information, and really encourage you to have this information accessible to you so that you can share it with women and help them in the decisions that they're making around their drinking. So low-risk drinking guidelines, there's some variations across Canada. This is what the Society of Obstetricians and Gynecologists of Canada noted in their recent guidelines in 2010, and it's drawn from the Centre for Addiction and Mental Health in Ontario. So low-risk drinking guidelines for women, no more than 2 standard drinks on any one day, no more than 9 standard drinks per week for women, 14 for men. And so as I said, between provinces you may see some variation in that. However, important to keep that in mind. If you're able to share some information with a woman who is thinking about getting pregnant in childbearing years, how might you share this? How, and then of course connecting that with her own experience. So this is the information we have about the general population. How does this fit for you? And of course, the guidelines don't apply under a number of circumstances, including if a woman's pregnant, trying to get pregnant, so it's also interesting to see that included now. I think that's a shift, or breastfeeding. And of course, the one major unique difference is the risk of alcohol use in pregnancy causing birth defects and developmental disabilities. And it's often considered the most profound sex and gender difference in alcohol use. And as I was mentioning earlier when we were looking at the rapid resumption, looking at the intersections and how this all connects for women. And so not seeing alcohol in isolation or outside of the context of her overall life. So women who use alcohol often also smoke. Women who are poor also smoke, and women who have abuse histories are more likely to drink alcohol and smoke. And the health risks are heightened for women who use multiple substances. So thinking about what resources do you have available in your program, at your service, in your community, that you could be sharing with women to help support you in this conversation. So it's not asking you to be an expert. It's just that you have an idea, that you're substance informed, that you have an idea of where you could get this information so that you can have this conversation with women. This is a resource that we developed at the Centre for Addiction, the BC Centre of Excellence for Women's Health as part of the Healthy Choices in Pregnancy project. It's available online at the hcip-bc.org website. Now certainly this cover would not appeal to many. It would be targeting a specific group of women. So this is one example of many. I know that nationally across Canada, there are some tremendous resources that have been developed by many different agencies. And so thinking about what would be most applicable, most suitable, most culturally relevant, etc., for your service. And this is one of the ones off the Government of Alberta, from the Government of Alberta. So what resources are available? What language level are they at? Who would they reach? Who would they be accessing? And what does it communicate to women as well? What's the message in it? Certainly you want a resource that balances that sense of importance of making the change, as well as giving women hope that they can do something differently, and resources if they do want support. And so given that this topic it's got many layers, it's loaded. And there's often many barriers. It's not the same as a woman breaking her arm and going to the system and asking for help. If a woman says, you know, I have some troubles with alcohol and I'm pregnant and I'm not sure what to do, she may get different responses. So very important to ground ourselves in that realization when we're wondering, why isn't she getting services? Why isn't she accessing help? Why hasn't she said something? So the barriers come in many forms: systemic, program, personal. At the program level, there can be guidelines set out around how many days she has to be substance-free. In theory, it makes sense. In practice, in real life, it may not be possible given her housing situation, her resources, etc. Personal barriers. Having to make the choice between possibly caring for your children and being able to leave the house or leave your community. This is a tremendous decision. There are lots of things to consider, possibly fears around who will take care of the child, if there's violence in a relationship, etc. And on the systemic level, looking at our policy practices, what sort of regulations, how are mothers represented? And this is some of the research that was done by Nancy in 2001, looking at the barriers that mothers mentioned. So shame, tremendous barrier, fear of losing their kids. So it's that position of wanting to ask for help, and at the same time, while asking for help, do you risk losing your children? And the fear of the prejudicial treatment based on their motherhood. And Lorraine Greaves and colleagues looked at stigma in terms of 3 Canadian papers over a period of time. And they looked at representation of women's responsibility in terms of a woman who had mental illness, who was experiencing violence or women abuse, and who had substance use concerns. So those with the mental illness problems, it was deemed as out of the woman's control. Women who were experiencing abuse, it was within her control. And substance use, it was deemed as deliberate, that it was her responsibility, she was making a choice. Now the representation of the system's responsibility in those 3 different situations with mental illness, mental health concerns, the system was failing them. There was some sort of gap in the system. Woman abuse, some responsibility for the woman, some responsibility for the system. And substance use, not the system's fault. And so the stigma is very real, very real. And you can imagine this may be the same woman. And so depending on which door, which service she accesses, how she will be greeted, how she will be treated, and the stigma that may follow her. And so it's really asking us to look at our systems, to look at the barriers. How are we welcoming women, or are we welcoming women to access care? And how we engage with women around alcohol. This is a survey from Best Start. So there's a survey of physician practices in Ontario, and most indicated that they talk to their patients about drinking, smoking, and drug use prior to conception, so looking at preconception practices. However, 43% of women surveyed in the 2009 Ontario FASD Awareness Survey indicated that they received no information or misinformation about alcohol and pregnancy. And so there's maybe a few things going on there. It's also what women are able to hear, how the information is communicated. It may not be that it's not communicated, it's how she's understanding it, how she's hearing it. And so some questions just to ground in that and to be reflecting for yourself. You may want to take some notes. You may want to take this away from the presentation today to be thinking about it. Take it away to share with your colleagues. In what way, if at all, has your understanding of women and alcohol shifted when you're thinking about who you're having conversations with? What might this mean for your practice based on what you've heard so far? What message are women given about how they will be treated when they access your service or program? And what influence might you have to reduce barriers at the program, policy, or personal level for women? What is possible for you in your role? If you're working as a mentor, a peer support person, a family member, what is possible for you to help support women with this very complex concern? So moving into the integrated framework to support practice. And can I get the time from someone, please? Perfect, thank you. This is a document that we also developed as part of the Healthy Choices in Pregnancy initiative, looking at the literature and putting together a framework for these conversations with women for this important work. So it's a better practices review. It's available also online from the Healthy Choices in Pregnancy website, hcip-bc.org. The recommended framework that came as a result of reviewing the literature is that it's a woman-centered, harm reduction-oriented, and a collaborative motivational interviewing approach that's taken. And so when we say women-centered, it's focusing on her health pre, during, and post-pregnancy and encouraging that sense of self-efficacy, that intrinsic motivation, that she's not only doing it for the baby, she's also doing it for herself. This is a really critical piece. And so it's looking at a mother-child unit, not as separate from each other. And as going back again to the SAMHSA research on the rapid resumption of substance use, how critical that is, because the health gains that she may make during her pregnancy, the hope is that the system and those around her can support her to maintain those changes into motherhood. And acknowledging the negative social responses to pregnant women with substance use and assisting with dealing with the stigma, punishment, and blame, recognizing what it takes for her to come to your office, to come to your program, to come to a system and say, I need some help. And that it's not only about the alcohol. The alcohol is the obvious concern. And we need to understand that within the larger context of her life and make those connections and recognize that change in one, you change one thing, everything is going to shift. And so looking at those links. And really understanding the possible realities behind some woman's experience. Now, you may not ever know her full story, all of the details. And we work in a way as if. We work in a trauma-informed way, knowing that many women have experienced some level of trauma in their life. And this classic study that people have probably heard many, many times, but the contribution that it's made to our understanding of birth moms of children with fetal alcohol syndrome is tremendous. So when they tried to find the moms of these children, what they found, of the 80 interviewed, the moms that they were able to find, 100% had been seriously sexually, physically, or emotionally abused. 80% had a major mental illness. And 80% lived with men who did not want them to quit drinking. And this is a very important piece to recognize, that women's lives are also happening in relationship, and how does that influence the decisions that they are able to make. And working in a substance-informed way, knowing that substance use happens on a continuum. And so we're talking about working with women at all levels of risk, knowing that some women you may meet with, a first conversation, 20 minutes, 5 minutes, may be enough. She needed a bit more information, she needed to connect that with her life, and she has the resources to make the changes. However, for some women who may be at the more extreme side of a continuum of use, this may be the first of many conversations. And so that opportunity to be the first person to connect with her, to build a long-term relationship. And so the overall principles of working in this way, recognizing the importance of reducing the harms, not getting focused solely on one topic or just the alcohol. It's alcohol in context of everything else. The key principles of harm reduction, that it's pragmatic, that it's practical. What does she need today? Is she hungry? Does she have the resources, the transportation to even come to your service? That it's human rights. It's a human right to be able to have access to care. Focusing on the harms, not only the substance. So what else is happening as a result of the substance? Variety of options, doors, and support. Focusing on immediate goals, priority of immediate goals, and having the voices of women heard throughout all of this work. Rather than telling them, we are eliciting from them what would be most helpful for you. And Bruce Alexander, this is a quote from Bruce Alexander, who was a professor at Simon Fraser University. And he says that we need to recognize that addiction can be a way of adapting to desperately difficult situations. People cannot be cured of adaptive strategies unless better alternatives are available to them. And so appreciating, again, connecting this with a trauma-informed approach, knowing that possibly her use of alcohol has helped her to cope to this point, has helped her to live in her body, live in this world to this point, and asking her to make tremendous changes in that without supporting her in other strategies, approaches, supports, connections with others, We need to be really looking at that. And another example for girls, looking at the interconnections. This is girls who experience physical and sexual abuse by dating partners and their risk of harmful behaviors after that. And so within 30 days, they were smoking heavily, 2.5 times more likely. As you go down the list, considered suicide, 5.7. Pregnancy, binge drinking, you can see the result of having that dating experience, the violent dating experience, and the behaviors that may come as a result of that. And there's a number of things, that barriers that can get in the way of us having these conversations, or we may think we're having them. And it really asks us to think about how we are having these conversations. And so oftentimes physicians report they don't feel fully prepared to discuss substance use with women. And understandably, once that conversation begins, then what? Are the resources available? Are you working in an urban community or a rural community? Who else can help you with this? I certainly know physicians that I've done training with. Their heart is absolutely, they dearly want to help. And then there's concerns around, well, if I put it on the chart or if I document, what does that mean? How does that follow the woman, et cetera, et cetera. So there's a lot of work to be done around this and to be supporting each other as a community effort. Of course, the fear and judgment and the approach that's taking. Often, there's time pressures, there's systemic pressures, et cetera, and that can translate then into providing information when we haven't asked her what she already knows, making assumptions, and offering this advice without permission. This is a note from a study that was done in Saskatchewan. It was a recent survey of physicians and nurse practitioners. And so while the majority reported that they always or sometimes ask pregnant women about alcohol use, only 39.9% of physicians and 34.1% of nurse practitioners reported that they rarely or never use brief motivational techniques. And so the piece that I also want to add to that is there's actually almost zero correlation between what we think we're doing and what we're doing when it comes to using a motivational interviewing approach. And so this collaborative approach, using motivational interviewing as the how to have the conversation. So motivational interviewing, it's collaborative, it's person-centered, it's a form of guiding to elicit and strengthen motivation for change. And so in the short version, it's a evidence-based communication style to support change. And if you put it in the context of what you're already doing, I think oftentimes there's maybe misinformation or misunderstanding about how long it takes to have a motivational interviewing conversation. It can happen in the briefest of contexts. You have a consciousness and awareness of what you're trying to do, where you're trying to guide the conversation. It doesn't have to be an hour-long session. And so thinking about your communication style already, and 3 different approaches: following, directing, and guiding. For the most part, people are quite good at following, building relationship, getting the story. And then what I hear commonly in training sessions is that they don't know how to get out of that. They start to go in circles, it's the same story over and over, nothing changes. And that's where skillful guiding comes in, and it takes practice. It takes practice and an awareness to know what you're actually trying to do. And then of course the directing is, I know what your problem is, I know how you can fix it on the extreme side of it. And certainly we know that that's not the most helpful when it comes to supporting health behavior change. However, there certainly is a place for directing. If there's ethical concerns, medical concerns, emergencies, you will be moving to a more directive style. Now, motivational interviewing sits in the guiding spot. It's considered a refined form of guiding. So just briefly, history. It came out of research around problem drinking. There's numerous studies, lots written on it at this point. Note the websites there. There has been some changes in terms of the website, so those of you that are familiar or this is new, please note those changes. As I've mentioned, it's a brief intervention. Dr. Miller talks about that if you can play the piano in a brief amount of time, you can also have a MI conversation in a brief amount of time. Now, that also requires some practice to get to that level, but it is possible, and it is possible. Really important that it supports engagement, retention, and completion of treatment. So when we're thinking about working with women at levels of risk, and the highest level of risk, the concern around even them accessing services. So if there's an approach that can help with engagement, this is something that we need to be looking at. And that helps her come back and complete. It's really an important component to be adding to what you're already doing. That it's learnable, effective cross-culturally. There's a really nice manual, Native American manual that's available online. I have the the information at the end of the presentation, that it's measurable. You can actually see, are you having an MI conversation? And so oftentimes there's not enough work done around that piece. In the research, you want to be sure that they're checking fidelity. Is it really an MI conversation? Otherwise, what happens is we can then say, well, it doesn't work. And we need to know, was that actually what was happening to begin with? And then it works with other approaches. So putting them together, they describe it as a synergistic effect. So adding it to cognitive behavioral, other approaches that can be helpful for that and as an adjunct. And specifically looking at supporting the health of women in childbearing years, I've just pulled a couple of studies. People that are really keen about research, I'm happy to send you more. I just wanted to hit a couple of highlights that are specific to reducing the risk of alcohol-exposed pregnancies. So this first one, Project Choices, many people are probably familiar. This was a 4-session intervention plus a contraception counseling session. Now, what I want to stress is that Project Choices was done, it was quite a large sample, over 800 women, randomized trial, and it was done with women at all levels of risk. Now, some women were recruited from jails, community health centers, different types of clinics. So these were women who have varying degrees of risk in their life and lots of things going on. And with that study, it was a 69% reduction in alcohol-exposed pregnancies with this intervention. Now, the balance intervention, it's building on work that Karen Ingersoll did in 2005. And so this is a new journal article that's just come out. And it's a 1 session, okay? So Project Choices was 4 plus contraception. Balance is 1 session. Now, I want to stress that the population was different. So with this group, we're looking at college-age women who are at risk of having an alcohol-exposed pregnancy. So you're seeing the variation there. Now, what they found, it's motivational interviewing plus feedback, was an 80% reduction in the risk of alcohol-exposed pregnancy. So whether women changed their contraception use or whether they changed their binge drinking, overall it was an 80% reduction in alcohol-exposed pregnancies. So looking at similar, both are based in motivational interviewing, both offer choice, both looked at not only alcohol use, they looked at contraception use as well. This one, case management enhanced with MI strategies, is an example of MI added to something else and how it supports that. So those of you that are working with women at the highest risk, who they themselves may have a degree of FASD, this study may be particular of interest for you. And so what it was looking at case management, so very intensive support for some families. And it was Native American women, 4 different Northern Plains communities in the US. And so they added motivational interviewing approaches plus the case management and found some positive results with that. And so I really want to stress, it's not about having one conversation with women and everything changes. There may need to be tremendous amounts of community supports, infrastructure built in to be supporting women who are certainly at the highest risk, and thinking about how this sort of approach can assist with that. But it's certainly not in isolation of all of the other approaches. And this last one, also an interesting study, I think one of the first of its kind, it's The Power of You, it's called. And it was looking at a program for homeless young women in transition to adulthood. And truly harm reduction, because they were looking at alcohol and drug, they were looking at HIV, as well as intimate partner violence. And so they did focus groups with these young women who were obviously at quite a level of risk as they transitioned. These young women were in shelters at the time of the intervention. And they reported, the feedback from them was that this sort of approach, using a motivational interviewing approach, fit quite well for them. So overall, this approach is a collaborative, evocative, it's working to draw out reasons for change from the person and always respecting and honoring autonomy. Now, there may be times when there isn't a whole lot of choice, and wherever you can offer it, this is stressed. And linking it with the trauma-informed work. As I mentioned, Nancy Poole did a presentation on this, I believe it was in February of this year. And so if you want more detail, I would recommend that you look at that in the learning series on the website. And so looking at that services and systems take into account knowledge of the impact of trauma. You do not have to be a trauma specialist. However, you're working in a way that you know there may be more to the story. You understand behaviors and reactions in a bit of a different way and don't respond to the obvious. You know that there's layers behind that. And the parallels between motivational interviewing and trauma-informed principles, you can see in some cases it's the exact same language, and so they fit really well together. There's an emphasis on empowerment, emphasis on safety, etc. And my colleague Francis Jeshura and I, we have a chapter coming out in a book that's being published by the Center for Addiction and Mental Health. Nancy Poole and Lorraine Greaves are the editors of that book. And the chapter that we contributed, was about looking at motivational interviewing and trauma-informed practice together. So again, self-reflection questions. How are these frameworks reflected in what you're already doing? What are the guiding principles? Is there anything that you might add or shift or adjust? What areas might need more support? And also what training opportunities are available for you, your staff, community partners, etc. Can I please have the time? Perfect. Thank you.
Just to let people know
Mm-hmm.
that the handouts will be available on the CNC website. Everybody loves your handouts.
Okay.
They're wanting them.
Okay, so I hear there's a demand for the handouts, is the feedback that I'm getting, and rest assured they will be available online for you to print off at a later time. Okay, so for me this is the fun part. This is the moving into the how and talking about what might these conversations sound like. So let's just pause for a second. I've done a lot of talking. As an MI trainer, it's out of character to do so much talking. So think about, I'm going to ask you all to reflect for a minute. I want you to think about something real to you that you want to change, you should change, you need to change, and you haven't done it yet. Okay? So just pause for a second. There's some chuckles in the room. Hopefully online you're thinking about different things in your life. Maybe someone else has told you should do it. So sit with that for a minute. And I'm going to make a few comments. And I want you to notice what happens, how you respond. In your mind, you don't have to say it out loud. I want you to notice what happens in your body, in your mind, your reaction, okay? And I want to stress this is absolutely not motivational interviewing, okay? So I'm guessing whatever it is that you're thinking about, the change you're considering, you've been thinking about it for a while. And really, something needs to happen. It needs to change. It's been too long. Other people have done it before. There's no reason why you shouldn't be able to do it. I've got some great ideas of how you can do it. I'm going to share those with you. And I really need to ask you to commit to me that you will make this change by next week. Okay, pause. Some chuckles. And now this is the part where I have to literally talk to myself and guess at what you were thinking. I would generally elicit this from a group. But I'm imagining some of the comments I've heard before. I'm imagining that you're thinking to yourself, yeah, I've been thinking about it for a long time, and I don't need you to tell me how to do it. I've tried many different things. You don't even know what I've tried. You don't know what my life is like. And by next week, not a chance. Not a chance. I'm guessing for the most part, that's the majority of the reaction. Some who are at a different level of readiness might be thinking, yeah, bring it on. I'm ready to go. Let's get the plan. Those people are at a very different place than the majority of us. And so noticing that, noticing what your response was, because what I just did was I tried to persuade you to do it. I tried to talk you into it. I made assumptions about you, and chances are I drew out all the reasons why you can't do it. Some people may have even heard themselves say, well, yeah, but. That is not what you want to be doing. If you get into a yeah, but conversation, you want to get out of that quickly, because I've actually drawn out all the reasons not to change, and you are now literally talking yourselves out of change. Okay, so we need to do it a different way, and that's what I'm going to show you. And so it's so easy to get into this. You would thinking that, knowing alcohol and tobacco can hurt your baby would be enough to get help and make changes. You would think. You would think that having your children removed would be enough to leave a violent relationship and stop using substances. You would think. And it's not. It's often not. And so there's more going on. We are much more complex beings than that. Most of us know there's a lot of things that would be good for us that we should do. Imagine the last time you went to the dentist. The hygienist said to you, how many times a week do you floss? Some people, maybe you're fabulous and you do it twice a day, 3 times a day, and that's wonderful. I would imagine others might have fudged it a little bit. It's human behavior, right? We're looking at what do they want to hear? What should I tell them? And so that's a simple example. Never mind something like this where there's a power dynamic and someone could literally take your children away. And so what happens if we get caught in that you would think thinking and we get stuck, it then can translate into what we try to do. And so we think if we just give them insight, you can just make people see, then they will change. Give them knowledge, one more pamphlet, just a bit more information, give them skills, one more coping skill and she will get it. Or we give them hell. If we can just make people bad enough or afraid enough, that then they'll do it. And for the most part, at some level, we all know what would be better for us. So it's not a matter of should I or shouldn't I. It's often can I or can't I? And then that in turn leads to will I or won't I? And we, for the most part, we miss the can I, can't I. It's the resources, it's that sense of confidence that I can actually do it. So in a motivational interviewing approach, the lack of change isn't denial, it's not stubbornness or stupidity, but it's often this language of ambivalence, that it is human nature to have mixed feelings about change. And so when we're thinking about alcohol and pregnancy, and particularly a woman who may be pregnant, if we jump right into the alcohol use or other substance use or tobacco, etc., we may have even missed the piece about how is she feeling about the pregnancy? How did the pregnancy come about? Chances are she's got some pretty mixed feelings there too. And so noticing our responses to that as well, is our first response congratulations, or is it, and so how is this sitting with you? This is new information, you're kind of surprised by this today. What are you thinking? That's a very different approach. So you can imagine these mixed feelings, there's kind of two sides to it. There's the pros, all the reasons why you should change, and then the cons, all the reasons not to. And so what I did in that initial example was I was giving you all the reasons to do it. And I naturally drew out all the reasons not to. So what happens is we get on opposite sides of the ambivalence, and we literally can have tunnel vision where we cannot see the other person's perspective. And so maybe this graphic, this image, you'll keep that in mind when you go into the next conversation with someone. Do I have tunnel vision or tire vision? However you want to look at it, whatever is going to make you remember which side of the ambivalence are you on. That alone, recognizing when you get into that persuasive place, will help you in your conversations. Not only professionally, chances are it will shift things personally and with each other as colleagues. So one strategy, and I want to be very clear whenever I introduce a strategy or a skill, these strategies in isolation of the overall framework, of the overall principles, are not a motivational interviewing approach. Okay? You can take a decisional balance and use it in many different contexts. I'm talking about it today, I'm talking about it in the context of a women-centered, of a trauma-informed, of a harm reduction approach. Okay, there's a larger context to this. And so this is one example of a resource that you could use with someone, you could use with a woman depending on how much time you have. In the briefest of interactions, you may just ask her, what are some of the good things about your alcohol use? Get a couple of ideas from her, reflect that back, and then you're able to go to the other side because she doesn't have to defend that now. What are some of the not so good? And I would even add, if anything. We can't make that assumption. And so that gives her the space to actually be able to talk about it because now she's not being pushed. If you have more time, this could even be a written activity. Now, again, depending on who you're working with, if there's cognitive challenges, etc., anxiety, there could be lots of things going on. This might be something that you work through together, that they take away, you do part of it, etc. It's kind of a living document as things shift and change. And so overall, working in this way is this idea of the myth of the unmotivated person that comes from motivational interviewing, that no person is completely unmotivated. So this is quite a shift. It influences our practice because it asks us to be responsible to recognize our role in this conversation, our role in influencing motivation, and our role in influencing resistance. So from this perspective, resistance happens in relationship. It's not about that resistant woman. So it asks a lot from service providers to shift our understanding of our role and not continue to put it on the other, certainly. And so working to avoid that persuasion, that righting reflex is the language that's used. So the righting reflex is that desire to fix or to make better, to stop, even prevent. For example, if you know a woman, she's come into your program, clearly things are really not going well at home, there's been some violence, and she says, yeah, I'm going to go back tonight. I think he's cooled down enough. So the writing reflex just starts to charge. You can feel it bubbling up, and understandably, noticing that and thinking about how you're going to manage it, because the last thing you want to do is have her talk herself into to defend the person. Okay? You want her to be able to feel mixed feelings about it and hold both sides of it for her. And at the same time, of course, recognizing safety planning, doing all of those key things that are critical at that point as well. So to avoid persuasion, you want to pause, you want to honor that ambivalence, knowing that there's two sides of it. If you start to argue one, she will take the other. And it's this shift in thinking from why isn't she motivated to for what is she motivated. Now, I may have my own agenda, and that's often what happens when we say someone's not motivated or they don't care. Chances are it's because they're not doing what we want them to do. That doesn't mean that she's not motivated for anything. It just requires us to let go of that a little bit and shift the energy. And you can use the decisional balance as a tool. So the decisional balance can be quite helpful in that context because it kind of contains that conversation. So even though you may just want to go to all the benefits of change, it's asking you to broaden that conversation. So some of the self-reflection questions. How do you know when your writing reflex is coming up? What do you notice in your body? Do you tense? Do you talk more? Do you move to a directive style of communication? Really important to notice what's happening for you at that time, and how do you manage it? Is there someone you can have a conversation with? What sort of supports do you have? How will you work through that? And another self-reflection might be considering a time when you were able to make a change successfully. What helped? What got in the way? How might this inform your work with women while making changes to their alcohol use or other areas of their lives? So really sitting with the changes you've made in your life, that one helpful conversation, what was it that someone said? Really recognizing things that just got in the way or turned you the other direction. Okay. Are there any questions that are coming up at this moment? Okay. Can I get the time again, please?
10 to 10.
Perfect. Okay. So another important ingredient, so the one of the key ingredients that we have so far is this understanding of ambivalence. Okay? Another kind of more the technical ingredient is this recognition of what's called change talk. And so you can imagine if I were to say to someone, do you swear to tell the truth, the whole truth, and nothing but the truth? Someone might say, I want to. They might say, I could. I have good reason to. I need to. I will. So hearing those, thinking to yourself, which one do you really think might tell the truth? I'm hoping you're saying I will. And so what happened in the research was they started to look at the conversations and try and figure out, how is this working? What are people saying? And so Dr. Miller and Steve Rolnick, they worked with a psycholinguist to really break down what was going on in these conversations. And what they found was this concept of change talk. So it's the pieces around desire, the ability, do I really think I can do this, the reasons, the needs, are kind of the building blocks or the infrastructure, and then the commitment. So this map of it, for some this might be too much information, for others this is just what you needed. So as always, take what you want and leave the rest. So what can happen is when we get into conversations or in brief interventions is that we build relationship, and then we oftentimes will ask for commitment too early. And then we wonder what happened. Why did this person backtrack? Things seem to be going so well. What could be happening is there wasn't enough time spent on the foundation, on the building blocks that actually lead into change. So the desirability, reasons, and needs. It's like not just asking people, when will you do it? Or what will you do? It's that question before it of why would you even want to? Often missed. And so it's the key piece that builds up. Now, to point out, the language that actually predicts change is commitment language, it's statements around I will, and it's also taking steps. I checked out that program, I made a phone call, I've tried this. That's the sort of language that actually predicts change. However, we need the building blocks to lead into it. And then we're not so surprised, when someone doesn't show up for a referral or doesn't come back next time, or, she told me she would do it, but nothing happened. So there's some sort of, that's an indication there's some sort of disconnect, there's a discrepancy there that happened in that conversation. So part of the work is recognizing what's happening in your conversation. So these are skillful discussions, and often deceptively simple looking. And so it's training your ear to really be listening to what are women saying, what are families saying as you're having these conversations. And so if you look at these different statements, checking in with yourself, which ones would you say are change talk? So I wish that something could be different. You're hearing some desire in that. And you don't even need to worry so much about, is it desirability, reason, need? It's not so much about that. You just need to know, am I hearing this person talk themselves into change or not? And that's also a reflection of the way that you're communicating. So this is also going to be telling you, something's working here. I'm doing something right. The conversation's going in the direction I had hoped. I like to hang out with my friends and have a few drinks on the weekend. No, we're not hearing change talk in that. I was able to stop drinking for a month after the car accident. So they had some success there. I really want my baby to be healthy. Absolutely. I don't see what the big deal is. My neighbor's kids are fine and she smoked and drank through her pregnancies. We're not hearing change talk there. Okay? It would be very important how we choose to respond to that. For this purposes right now, we know we're not hearing change talk. I've already cut down from what I used to drink. So we're hearing taking steps. And I will stop drinking. That's the strongest of commitment. Okay? So it's training your ear. What are you hearing? So I want to put on a clip. It's about 8 minutes long, just under that. And it's from the DVD that we, again, did from the Healthy Choices in Pregnancy project. It's one of a number of clips. And it's bringing together, it's a conversation with a woman postpartum around alcohol. And it's also making the connections between substance use, between trauma, violence, and her mental health. Okay? So this is one example. The hope is that you're watching it, thinking about, what works, what doesn't work, what would fit for you, how you might adapt some of it. Certainly any demonstration you will ever see, it will be imperfect, and that's the beauty of it. I mean, our conversations are all imperfect. It's just practice, practice, practice. And so noticing, listen to what the woman is saying out loud, okay? Because again, we want to be thinking about our role is to help people hear themselves, okay? So notice how this service provider draws that out.
Throughout the interaction, the worker uses basic counseling skills known as OARS to evoke reasons from Kim why having a drink may not be the best answer, rather than telling her what to do. Asking about the good and not so good things about alcohol allows Kim the space to talk about what alcohol offers her and provides the worker with an opportunity to explore with Kim what she knows about the connections between violence, mental health, and substance use.
My mind it's all, mixed up. 1 minute, I'm fine, And then the next minute, everything just seems so hopeless.
What is hopeless?
Just look at my life, 2 years ago, I was happy. I was in a relationship, and I was looking forward to becoming a mother. And then, now, I am a mom of a 3-month-old baby. And Sarah and I had to leave and come to a safe house because we were afraid. kidding. I came so far from where I started just to get kicked back down again. Before the baby was born, my partner and I used to party and have fun with our friends all the time. Then, when I found out I was pregnant, of course, I got down. It was hard at first. Because it didn't seem real. And then when I started to show, I started feeling connected to the baby, you know? So I stopped drinking completely.
I think that's pretty amazing. It's a huge accomplishment. A lot of people would never be able to do that.
I wanted to have a healthy baby. I really wanted to be that for her.
How have things been going since she was born?
Every day is just so hard. After the baby was born, my partners, he assumed that I would go back to drinking and partying. And I told him different. He was not happy.
What's happening?
He used his head.
Can they hear it?
Maybe I like that video. I would walk around so fast all the time.
Do they have audio?
It took a lot of courage for you to stand up for yourself like that.
So I should stop it.
Look at where I am now.
If they have audio, I want to keep going.
I have a doctor telling me that I'm depressed. Do they have audio? I have a boyfriend that I'm afraid of. I have a 3-month-old who's depending on me. I've got no place to live and.
Hmm? It's not coming out.
I had a lot of stuff coming at me recently. I think it's probably just true for me if you're looking at a drink.
Okay, am I on now? Okay, so it's come to my understanding, to my attention, that unfortunately that people online were not able to see the clip. Some may have been able to hear, but at very limited levels. And so that said, that's too bad. And the clip we should be able to post after the session, okay? And so to capture what was happening, again, in a training session, I would ask you, what did you hear so far? But apparently not much. So, as I mentioned, the clip was a postpartum conversation. The woman had just come to a transition house with her baby and was struggling with the fact that she'd made changes to her drinking and now this urge was coming up. She's feeling depressed. She's got all of this stress, et cetera, and the service provider does quite a nice job, if you were able to see it or when you are able to see it, of drawing her out, of managing silence and pacing and timing. She goes with the woman. At the same time, you can sense that there is a guiding aspect to the conversation. There's a flow to it, and the service provider is getting to a place where she can have that conversation with her around what does she know about how alcohol can affect depression, her mental health. And that's where the conversation starts to go. So the service provider very skillfully makes the link between mental health and substance use. And ultimately, at the end of the clip, what you hear the woman say, not the service provider, what you hear the woman say is I guess it's not a very good idea for me then in terms of starting to drink again. And that's ultimately what you want to be happening in these sorts of conversations. She comes to her own conclusions through talking it through and not being pressured to make a change. Okay? So moving from that, let's just finish this piece and ground in what we started with and have an opposite experience of that. So when we first started this section, I'd asked you to think about something real to you that you need to change, should change, want to change, and you haven't done it yet. If I can ask you to go back to that, think about that again, that topic. And now I'm going to ask you a couple of different questions, and I want you to notice, what do you hear yourself say? Okay? So my questions are, why might you want to make the change you are considering? Why would you even want to do it? Not saying you're going to, but if you were. Notice, what are you saying to yourself? Okay? What would be 2 reasons for making this change? The top 2 reasons, if you were to do it. Notice what you're saying to yourself. Now the hope is, what you heard is change talk. There was no pressure that you had to do it. And so also notice my language, that you're able to have conversations about the possibility of change without putting pressure on women. So we can talk about the possibility, we can use hypothetical, and still be able to have this conversation. So if you were to do it, not saying you're going to, it takes the pressure off. Okay? So what we also saw demonstrated, or you will see demonstrated in that clip, were some of the core skills that are used to support engagement, also known as OARS. Now these skills are commonly used in any sort of counseling practices, communication styles, etc. Open questions, affirmations, reflective listening, and summary. And so again, it's about heightening your awareness of the types of skills that you're using and how you're using them. You're obviously already in conversation, but it's about becoming more aware of what types of skills you're using and when. So open questions. Those 2 questions I just asked you, those are very purposeful, very strategic questions to draw out change talk. And so having more questions like that in your conversations, you are actually able to guide. So it's questions like that that help to move from that following, where people say it just feels like we keep going in circles. If you just have 1 or 2 questions that you know will open it up to more change talk, that can then help you shift into a guiding style. Now, one of the other things to consider with open questions, again, depending on who you're working with, level of challenges that they may have, etc. Too many open questions may be too much, too many choices. So one way to adapt that, if you were working with someone who had a degree of FASD, would be to possibly use multiple choice. So having a couple of ideas. Would it be this, this, or this? That way it's not so open, it gives it some containment and some structure. You may end up also using a few more closed. At the same time, I would really encourage you to be aware of how many closed questions you are using. It can really shut people down. Asking too many questions overall can create a bit of a power dynamic in that I ask the questions and you answer. So working in a trauma-informed way, you also want to be noticing that as well. Okay? Many of the standard assessments and intakes, etc., a lot of those answers can be gotten to and that information gathered in a different way. We don't necessarily have to be going question by question. Affirmation's a very important part of this conversation. It's about recognizing what she's already doing and giving some concrete examples and reflecting that back to her. Now that's different from praise. Praise sounds more like, good job, great work. There's nothing kind of anchoring that or connecting to that sense of intrinsic motivation. So an affirmation is different from praise. Reflective listening, critical skill, very helpful in building engagement and safety in relationship. Now again, an adaptation with that, if you're working with people who may have a degree of FASD, you may want to keep your reflections more simple. You wouldn't be talking in metaphors. That's not helpful. So keeping your reflections more concrete. But certainly there is a place for reflection. It helps you stay in tune. It helps you follow the conversation. And it communicates to the person that you're speaking with that I'm trying to understand you. I'm trying to get it. Okay? And then a summary, very helpful skill. If you're thinking about the importance of repetition, about gathering thoughts, collecting ideas, summary can be a very important skill for that. It just takes some practice. Summary is also a very useful skill if you're thinking about containment. Again, working in a trauma-informed way. Someone comes in, there's so much going on, there's so much in the room all of a sudden, and you're trying to catch your breath yourself. You're thinking, okay, where do we start? And so summary can be a very useful skill for that, to just putting some containment and safety around that conversation. So some examples of open questions, I'm certainly not going to read through them all, but some of these can be helpful to get that conversation started, and also to draw out her reasons for change. So for example, what makes you think that you need to do something about? What do you think will happen if nothing changes? All of those potentially will bring out change talk. Questions that more specifically around alcohol, getting the conversation around that. You know, tell me a bit about where alcohol fit in before you knew you were pregnant. That's a bit of a safer conversation. And then you can follow that up with what changes, if any, have you made since knowing? So there's no assumption that she has either when I add that little if any. No assumptions and no judgment around that. So these, I just wanted to pull some examples straight out of the DVD clip so you would get a sense of how these skills were demonstrated throughout that. So open questions, she even just started with, you know, what feels hopeless? It's kind of tell me a bit about what's going on for you. How have things been going since she was born? Getting a sense of where she's at now. What do you know about how alcohol can affect your mood, was how she opened that last part of the conversation. An affirmation. She really reiterated that a lot of people wouldn't have been able to do that, to quit drinking when she was pregnant. So that was a huge accomplishment. And it was grounded in something tangible that the woman could see she was able to do. And that it took a lot of courage for her to stand up for herself, to actually be able to leave her partner and come and get services. You saw reflections throughout that. Things didn't turn out like you planned. Alcohol takes your worries away. And then when you make a statement like that, she's not agreeing with her. What you're saying, though, is what I'm hearing you say is that alcohol really helps to take your worries away. Now, the hope is with a reflection like that, is she comes back and says, and in the clip she does come back and say, well, yeah, but they're still there in the morning. And so it keeps them going. And then a summary. You've had a lot of stuff come at you recently. It's perfectly normal that you would want to drink. And you said before the alcohol helps you escape for a while, what else does it help you do? So she summarizes and she keeps the conversation going, continuing to find out what benefits does this give you, and then that creates the opportunity to go to what downsides, if any. So just to see how those skills come out in a clip like that. So I wanted to try a bit of an exercise. Even in this context, it's not ideal, and at the same time, it can be quite helpful. This is the part where I really encourage you, if you have a piece of paper, a pen, to take it out and try some of these, okay? The point of doing this exercise is to really highlight the role that reflections can play in building relationship and safety, and especially in these early stages of these sometimes challenging and sensitive conversations. These are tender conversations. And so I'm going to go through a number of statements you might hear a woman say. And I want you to notice, think about what your first response is. And then, based on what you've heard so far, how you might respond. Watch for your writing reflex. What starts to come up for you? Notice that. Do you want to jump right into questions? Do you want to jump right into fixing? Okay? And so I'll go through a number of these. I'll pause, and then I'll offer some ideas. Now, there certainly is no one answer. I want to stress that, okay? The bottom line is that you want to be practicing staying in reflections, not moving to questions, and not fixing, okay? So a statement like, yeah, I admit I drink more than I should sometimes. So you've just met with her, she's come in, she's kind of casual about it. She's watching you. She's trying to see what's your reaction going to be. So notice what comes up for you, think about how you might respond. What would you say next? So a couple of ideas around that. You've been paying attention. Pause. I'm not getting pulled in. You've been noticing some changes. And so you can hear how reflection like that keeps that conversation going. I'm noticing what she is doing, not what she's not doing. And chances are she'll be surprised by statements like that as well. She's expecting someone to give her the riot act, tell her all the reasons why, et cetera, et cetera. So it's really asking us in the way that we communicate to change this up. We need to be having different conversations with people. Okay. Then she says, I try to stay away from the hard stuff. Usually it's just beer and coolers. Watch your writing reflex. Noticing what's coming up for you. What do you want to say next? But you're not going to. What do you want to say next? My guess is you want to go into, well, you know that all alcohol is the same, et cetera, et cetera, et cetera. And here's the pamphlet. Okay? And then what just happened to her? Shut down. Shut down. And we go into, yeah, but. Okay, so we need to do this differently. So you're going to take a deep breath, you're going to ground yourself, and you're going to keep going with the conversation. Okay? I try to stay away from the hard stuff. Usually it's just beer and coolers. So what might you say? You want to be thinking about what is she already doing? What is maybe the core value that you're hearing behind that statement? Not the shock value, the core value. Okay? So you might say something like, you know, you're making some decisions to protect your health. Chances are she's not expecting that. You're really making some conscious decisions to protect your health and your baby's health. You're making the best decisions you know to make right now. And again, you're going to pause. Okay? And then she says, well, I'm not drinking enough to cause any problems with my pregnancy. Deep breath. Writing reflex is still there. It's probably louder. Okay? And you're just, the whole point is you're going to stay with her. Stay with her. You want to be thinking in your mind, your whole goal of this conversation is she keeps talking, she stays, and hopefully she comes back. So stay with her. I'm not drinking enough to cause any problems with my pregnancy. Okay, now listen at a different level. What might you be hearing behind that? What might you be hearing? You might reflect something like, it's really important for you to have a healthy pregnancy. You want a healthy baby. Okay, so you're listening at a deeper level. What is her core value? What is she really saying behind that? The person who has a problem with drinking is my boyfriend. Now, people hear that in different ways. Again, what might she be saying behind that? You might say, and you're not so sure how he'd react if you made some changes. That might be what she's trying to communicate. I don't know. But when you work in this way with reflective listening, it's a guess. It's a guess. And she will correct me. That's not what I'm saying. He doesn't care. Okay, that's a different conversation. But the bottom line is we're still talking. Okay? You've got some concerns about his drinking. You've got some worries. And that could lead to a whole conversation down the line about what that will look like once the baby's here. Who knows where this could go? Okay, but if you had gone right into information and pamphlets 2 statements ago, you would never get to that place with her. Okay? And then final statement. If I stop drinking right now, I know it couldn't hurt things, especially for the baby. So interestingly, she has come to this conclusion. You didn't have to tell her. She knows at some level. Okay? You want to make the best decision that you can. And you want things to turn out well. You want things to be different this time. And that may involve stopping drinking. So she's hearing that come back to her one more time. So it just takes some practice in working in this way. And you'll find that you get into the flow, you'll start listening at a deeper level. One of the responses we had from some training that we did with a group is almost fear around, oh my goodness, women are talking now and we don't know what to do with it. The statement was the conversations have changed. And it's a whole other level of connection and relationship. Now, I certainly don't want to leave it there, though. I know that people are thinking, okay, but you got to tell her about the alcohol and the beer and the coolers and et cetera, et cetera. Absolutely you do. And so I'm going to give you an idea of how you come back to that in a little bit, okay? You certainly don't want to leave the conversation in that place because you also have an ethical, legal responsibility, medical responsibility to check in around what does she know, okay? And so that's the piece around providing information in an MI way, in a trauma-informed way. I'm going to come back to that. So you would link that with this conversation. It's more about pacing and timing. Can I get the time?
Yeah, 10:22.
Okay, great.
Christine, can you just share with people that little note I gave you?
Oh, I'm sorry. Yeah. Okay, so there's a reminder for everyone watching that you need to sign in before the webcast ends. And it's the red line above viewing screen is the link to sign in. Okay. And so that's so that they get a certificate, is that?
Yeah.
Okay. So if you want your certificate, sign in, folks. Okay. So some strategies for building engagement and motivation. So we just talked about those skills. Those skills are woven in through everything, okay? Now I'm going to talk about some more strategies. One idea for opening the conversation is creating your own opening statement. Now, I'm imagining that you already have various forms of it. And so it's about thinking about what you already are doing. And there are a couple of other pieces that you might want to add or shift or stress within that statement. So taking this back to when I started today, I knew some of the key things I wanted to do as I opened the session here was to offer an affirmation and appreciation for people taking the time, to give you a clear sense of what our time together would look like so you have some parameters around that, and to also stress autonomy, that you can take this information, use what's helpful, and the rest you can leave it. There's always choice in the work that we're doing. And so that was a very purposeful opening statement that I started the session with today. Now similarly, as you're thinking about your work with individuals or families, what might that sound like for you? So it's taking all of those guiding principles and weaving them together in your opening statement. So for example, our time today may be different than with other people we've talked to. I'm not here to tell you what to do or how to change, but rather to find out what's going on in your life and help you make the changes you decide to make. Now that's a very different beginning than I'm imagining most women or many women have had. So just even for yourself, imagine going to the physician, going for your checkup, going for some sort of procedure, and that's how the conversation starts. What a shift. Immediate shift in energy, immediate sense of there's this collaboration that we're here to work on this together. Another example, everyone has different experiences and different reasons for coming here. So this might be a situation where a woman's been told to come see you. It's not always by choice. I'd like to know more about your experiences so that I can be most helpful to you in working towards your goals. Tell me a little bit about how alcohol fits in your life. So ending that with an open question to get the conversation going. So thinking through, what is your opening statement? What are some of the key pieces you would want to include in there? How do you actually make collaboration explicit? How do you make respect for autonomy explicit? We talk a lot about in our work about these principles, and it's principle-based work. We need to be thinking more about, okay, so what does that actually sound like? How do you communicate that to the people that you're working with? So it's not just an idea we have in our mind, it's explicit in the way that we communicate the language that we use. Another example of a strategy is to use agenda setting. So this is a collaborative approach to getting the conversation started. There's a number of benefits to this approach, and it's vital to focus on areas that women can control. So Stephanie Wahib at Portland State University did some writing about this, and this is from an article that she wrote about looking at women experiencing violence, the role of motivational interviewing, and that we need to really be thinking about areas that she can control. What is within her scope, within her realm? And so you can imagine you might have a sheet with some circles on it is one way of doing it, some bubbles. And you put in the key areas that you and your service or kind of program areas, the topics, the conversations that you have with all women who come in. Okay? So for example, you know, a lot of the women that come into our service want to talk about some parenting skills. We also have some resources around food, housing, and we also have conversations with women around alcohol, tobacco, and other substances. And I'm wondering if there's anything that's not here that you would like to add. So in terms of the collaborative agenda setting, you're getting her voice, you're finding out what's most important for her, and you're adding that in, not making any assumptions. Okay? Now, at that point, then you find out, so of all of these topics, where would you like to start? What would be most helpful to start with?
So we have a question.
Okay.
Actually from Cecilia in Ottawa, Alberta.
How can motivational interviewing be used when nutrition is an issue in terms of the fetus development?
Mm-hmm.
I'm wondering if you can
Weave that in.
leave that in. That'd be
Exactly.
great.
And so is she a
What's the
nutritionist?
relationship between nutrition and the relationship between nutrition and alcohol effects?
That sounds like a bigger,
Bigger
more
question.
technical discussion.
Yeah.
But in terms of weaving it in,
Yeah.
now is she a nutritionist? Is that the lens she's coming from? Okay. So depending on your role, this is a really helpful tool to help explain the areas that you cover. So for example, the question was around nutrition. You could have an agenda setting chart like this, and it could be more specific nutrition topics. So breaking the overall nutrition theme down into smaller subgroups like prenatal vitamins, et cetera, et cetera. So rather than having this broad scope of parenting skills and connection with others, you would take nutrition and break that down into smaller topics. So I'm hoping that that's helpful. And it helps to communicate, these are the topics I know a bit about, these are some of the areas I could help you with, and then she's also able to add her questions in there as well. So it can be used in many different ways, Another adaptation is to use images instead of words. So also with the nutrition, you could be using images. It could be culturally relevant, et cetera, et cetera. Another adaptation would be certainly 5 to 7 bubbles topics may be way too much for some people. Take it down to 2 or 3, or have 2 topics and then 1 blank, because you absolutely want to get their voice in terms of what's most important to them, and we oftentimes can't even guess sometimes what people come in with. And so using that as an adaptation. So this is the piece I wanted to come back to in terms of linking up the conversation when we did the in the moment exercise and we had the different statements. This is the piece around providing information in a different way. So not assuming she doesn't have it, not assuming she doesn't know, but taking a few steps in and really encouraging you to get used to this flow as it just starts to become secondhand in terms of providing information. So the woman said to you earlier in the conversation about the beer and coolers, she doesn't drink the hard stuff. So you definitely want to come back to that, okay? So you finish that first part of the conversation and then you link it up. You know, I'm wondering, you mentioned a little earlier about really consciously choosing not to drink the hard stuff that's important to you to reduce that risk. And I'm wondering, what else do you know about the impact of alcohol on pregnancy? And then you find out what else she's heard. Well, my friend said this or that, and even saying, what have you heard, not what do you know? What have you heard is there's no shame in that. It's kind of someone else told me. It's not that I don't know the answer, okay? So you find out what exactly is it that she's heard, and then ask permission to provide more information. So a bit of what you've said is absolutely true. There certainly are some pretty big concerns around hard alcohol, and we also have some concerns around all liquor. Can I tell you a bit about that? The research continues to grow. At this point, we know there really is no safe time, no safe amount, and it's ultimately safest not to drink. And so having that conversation with her. So providing the information and finishing with asking about how this information specifically connects to her experience. Again, the whole point is you want to draw out, you want her to hear herself make this connection, okay? We can provide lots of information, lots of wisdom and advice, and if we never know how she links it, we don't know if it's been effective or not, what she's actually heard. She might walk out the door thinking, well, that's fine for other people, but everyone in my family smoke and drank and everyone's fine. It doesn't relate to her, and you may not know that piece if you don't close this loop. So closing the loop, so find out how she understands the information. What do you make of this? How does it fit in with your experience? I appreciate that it's new information, and you weren't even necessarily expecting to talk about this today. So it may come as a surprise. And so now hearing that all alcohol really is the same and it's safest not to drink, wondering where is that landing with you? How does that fit for your experience? What sense do you make of that? So connecting it back with her experience. So again, it's about pacing and timing, about coming back to the conversation and being able to make those links. Now, certainly there's some considerations. When someone asks you directly for information, you're not going to say, can I give it to you? They've already asked you. There's implicit permission in that. Many of you probably have had the experience where someone says to you, well, what would you do? Or tell me what to do. And so they want an answer. So one way to work with that so that you still honor choice and respect autonomy is to give a couple of ideas. What some women have mentioned to be helpful are this, this, and this, okay? Because you don't want to get into a position where there's only one option and one way of doing things. So you still want to offer choice wherever you can. And there's circumstances when it's ethically, medically required. It's not a matter of, can I tell you about? So some of the ways to kind of frame that or start that conversation, to announce that there's something that we need to talk about today so that they have a sense that this is a bigger conversation, this is an important conversation. Offering first choice. There's something that I need to tell you, but before I go ahead, is there something you would like to discuss first? So if they're coming in with some concerns, maybe about their other kids, they've been up all night, etc., you have that conversation and then you're able to come back. I really want to hear how you're feeling about it first. Or the other option, putting this may or may not concern you in the front of that. So all of those ways are examples of how you can bring that the spirit or the essence of this work, that idea of respecting autonomy, to life. Just that simple piece, this may or may not concern you. I'm saying, yes, you will make your own decision around this. You have some choice around this. And I need to share this with you. How are we doing for time?
10:33.
Okay, any other questions at this point?
There is one question.
Mhm.
This is from Jamie.
You know, Alert Bay.
Okay.
Would you use the why question, as I was told it was a blaming question? The
I'm not
why-
sure which
using
question.
why at the beginning of a question?
I feel like I need a little bit, I mean, I know the STEM, it's not encouraged to use that
Yeah.
as often.
Yeah. And so you've used other things like would and
Yeah.
that kind of thing.
What
Yeah.
might that look like?
Yeah, making other choices of the words, yes.
Yeah. And of course, you know, we're human, and sometimes the why questions pop out. And so part of the work is also recovery around, okay, you know, it just came out, and the priority is the relationship. And so it's about how do you get back out of that. And even just being transparent, part of this work is the transparency and the humility that, you know what, that didn't come out the way that I'd hoped. Let me try again. And so it's just backing up, having humility, and that helps to build the relationship. It helps to build safety in it, that, you know what, she's not so perfect either. Okay, one other strategy that may or may not be helpful is this idea of assessing readiness, okay? And so from this approach, readiness to change is understood in terms of it's the importance and it's the confidence. So what we often hear is people say, I want to do it, I need to do it, all those things. And so we think, okay, they will. And then we're surprised when they don't. And we miss the questions around, do you think you can? How might you do it? The confidence aspect of it. So one way to assess readiness is to use rulers, a 10-point ruler. So again, depending on who you're working with, the visual cue may be very helpful. A lot of these strategies can be visual as well. So importance. How important is it for you to make a change? 0 to 10. 10 is totally important, 0 not at all. One adaptation that I've seen of that is in the Native American manual, where they actually use the progression of a seedling to a plant. And so you're using different images, more culturally appropriate, etc. Some of the clinicians I've worked with at Children's Hospital and in BC, they've talked about using color coding, so from red to green, in terms of the progression of where a child is at. So if you're working with younger kids or youth, that would be another idea. Another example is the development of creation of moccasins. So from the hide to the completed moccasin is another way to show progression. And so being as creative as you can with these sorts of tools, there's no one way to do it. It's more a matter of thinking through that you have an understanding of why you're doing it, you know why, and then adapting it to how it would work best. And so part of the reason, one of the whys of you would use this sort of tool is to assess importance and confidence, and also to draw out change talk. I've seen different resources where they do a ruler, but then there's no follow-up questions to it. And so you miss the opportunity to actually draw out the change talk. It was a missed opportunity. So you do the rulers, and then you ask these strategic questions. Why are you a 4 and not a 0? So let's do this together, a self-reflection, okay? And I want you just to notice what you hear yourself say. So I will ask you 2 questions. The first one is around your importance. You may want to write it down, whatever works best for you. So your importance number, 0 to 10. How important is it for you to make the change that you were considering earlier? Let's stay with that same one. So something you want to change, need to change, should change, you haven't done it yet. How important is it for you to do it? 0 to 10. 10 totally, 0 not at all. So get your number. Okay? And then I'll ask you the follow-up questions. And notice, what do you hear yourself say? So why are you whatever number you are for importance and not a 0? Now the hope is you're hearing yourself say all the reasons why it is important. And that's change talk. Okay? Now if I had asked you, why are you whatever number you are and not a 10? Notice what you hear yourself say. All the reasons why it's not important. So it's, again, knowing why you're doing it and how to do this. There is a guiding aspect to it. It's skillful. You don't want to be drawing out all the reasons why not. You want to be drawing out all the reasons why. And then the next question, what would it take to go from whatever number you are to 1 point higher? What would increase your importance? What would have to happen for that importance number to go up? And chances are we know ourselves best. And we have an idea, well, I'd have to have a pretty big health scare, or, you know, my partner would have to threaten to leave me, or my kids would have to say something. If my kids noticed, that would bump my importance up. Okay? So again, with confidence, notice what your number is this time. How confident are you that you can actually make this change that you're considering? 0 to 10. 10, totally confident. 0, not at all. How confident are you can make the change you're considering? Notice your number. Now, what I find with most groups, confidence is a little bit lower. There tends to be a bit of an imbalance there. And at the same time, it's also very telling because for some people, their importance number may be high and their confidence may be high. And so what that would tell me is this person's ready for a plan. They're ready to take some next steps. It's not so much about ambivalence anymore. This is about, how do I do it? Let's get going here. Okay? Now, someone that has low importance, not that important to me, but I know I could do it if I wanted to, and I know I could do it if I wanted to, I would wonder, do they have the information that they need in terms of importance? Or perhaps this is someone else telling them that they need to do it. Maybe this isn't the for what are they ready. There's something else that's more of a priority right now. If they really wanted to, they could. However, there's competing priorities, and this cannot take their energy at this time. Okay? Now, someone that is low importance and low confidence, there may be a number of things going on. One thing to consider would be that I'm not going to tell you it's important to me because I don't think I can do it. And that wouldn't be a surprising scenario when we're talking about women and alcohol, especially if a woman has come through this many times. This is her 4th pregnancy, 5th pregnancy. She doesn't have her other children in care. She's not sure this time how she's going to do it. So yeah, I'm not going to tell you it's important because I don't think I can do it. And I don't want to set myself up for that shame and blame again. And so important to recognize how this information can inform where this conversation might go, how you might support her. If her importance is high and her confidence is low, in that sort of scenario, it's not so much about information anymore. She gets it. She knows there's concerns. However, she's not sure how to do it. And so that's where the resources, possibly case management support, etc., comes in. So any questions about that piece? No? We got a quiet group today.
You just turned up the volume. People were concerned about the volume. So
Oh, I'm the quiet one. Okay. That's unusual. Okay. Can I have a time check, please?
It's 10:41.
Good timing. Okay, so we're coming towards the end. It's a lot of information in a very short time, and ideally, you know, the hope is to evoke a curiosity, to engage so that you come back more. And so these are some guidelines that were developed by Wendy Reynolds and her group at AWARE. They do fantastic work over there in Ontario. And this is from the SMART Guide from early in 2002. And these guidelines still hold true. I mean, it's kind of capturing a summary of what I've been talking about being non-judgmental and empathic. And so working in this way, using these skills, using reflective listening, affirmations, helps you to communicate that throughout your conversations. Ask her what she already knows. Don't make assumptions, don't provide information without checking it out with her. She knows herself best. If she's been involved in the system, connected with the system for many years, she could probably tell you 10 ways to the center. And to dispel the myths. Work to understand the benefits of substances for her. There is something adaptive about the choices she has been making, and so that really reflects a trauma-informed approach, that it's adaptations. Encourage small steps for change. So we see that in the example of the rulers. It's the 0 to 1 that's often the hardest. It's the just getting started, putting one foot in front of the other. And keeping the conversation open, as you saw with the rapid resumption postpartum. This conversation does not end in pregnancy. It's an ongoing conversation. Keep that door open and communicate it in a way that no judgment, whatever happens, we may have missed something, come back. And talk about the benefits for both her and her children. So this mother-centered aspect of it, it's the mother-child unit. So it's not only do it for the health of your baby, it's also for your long-term health. What does your health look like as a mother? Is there a comment?
There is a question.
Okay.
Individual has a question on how this information can be used as a child care provider. It's a very open-ended question.
Okay. So I'm imagining many of your conversations are with the parents. And so that would be one of the key ways that you could be using this approach. I mean, a lot of the research and writing, there's actually a new book on Am I with Adolescents? But a lot of the research around pediatrics and working with kids is the conversations with the parents, the decision makers around behavioral interventions, etc., nutrition, who is making these decisions, who needs to follow through on care plans, etc. And so it would be thinking about what might that conversation sound like with parents. Yeah. Okay. And so wanted to also, I've been saying these pieces throughout. I just wanted to pull it together more succinctly in terms of FASD-informed adaptations. I've tried to mention it throughout the presentation, what it could look like with any of these approaches. And so this is from a resource also from Wendy Reynolds' group at AWARE. It's a newer resource, and I'll mention that in just a second. This idea of being flexible. It's kind of getting out of our own way, our own expectations, knowing that, if someone does have FAS, it will be the same conversation over and over and over. And to not be surprised by that, that's part of the work. This is part of the support. It's repetition, it's ongoing, it's keeping in relationship, and really shifting our sense of what success is and what the outcome should be. If people stay connected with the service, see you as a person to trust, that is a tremendous outcome. And with that support, with having those structures in place, and the system absolutely has got to support the frontline workers in doing this. It cannot be individuals alone, it has to be community-based. As I already mentioned, using more multiple choice versus open-ended, working in an FASD-informed way. And so it's not about going to the extreme of not having any choice. I've also heard conversations around that, that how can this possibly work? It's about adapting it and adjusting it. You still want to work in a way that's collaborative. You still want this person expressing their own concerns, fears, core values. You still want to be in these sorts of conversations. You may use more closed-ended. Again, just caution around that, to be aware of it, to recognize how many closed-ended questions, it could also shut people down. And it, like I said, creates a power dynamic. Keep your reflections more simple. You're not going into conversations around metaphors. Keep your conversations simple. Repetition, this is where the value of summary can come in. You may ask them to summarize. Okay? So what have you heard me say so far? Since you've come in, we've talked about a number of things. What are the two things that we just discussed that you're going to focus on today? Okay? The visual, agenda setting, rulers, how these tools can be used. Always having simplifying and fewer options. Asking permission to offer suggestions. This is something that we want to be doing in our work, in our conversations with most people, with all people. Working on those activities together. So for example, something like a decisional balance may be too complex. You're not going to set people up and ask them to take away and work on it on their own. What small, visual, simple tasks can you do together? It's truly a collaborative process. Writing things down and keep checking in. And so that's where that ask, provide, ask can be extremely helpful. If you just get into this, get familiar with the flow of that, and you're always closing the loop at the end. How do they understand what you have just said? Okay. And so some more reflection questions as we come towards the end. So begin to notice how many questions you ask and whether they're open or closed. How do women respond when they're asked a number of questions in a row? Are you noticing her shutting down? Is she checking out? Is she looking at her phone, her watch, whatever's going on? How might you integrate more reflections throughout your conversation? So even as a starting point, that could be one way to help you build relationship. What would your own opening statement sound like? How would you stress collaboration? How would you stress autonomy in that opening statement, and that you are not there to force her to make changes? What are some of the key topics you would include on an agenda setting chart? So thinking about, we had the nutrition example, thinking about your role, your clinic, your program, what are some of the key areas? And by being able to have those already down, it's like you get the tough conversations out there immediately. You're saying right away that we talk with women about alcohol, we talk with women about tobacco and other substances here. These are common conversations. So it's not about having to try and find a way to weave that in. It's already right there. You've already announced it. Another example, another adaptation of that, working with public health nurses, is when they're doing their perinatal groups. And so taking it into a group context. So some of these resources, certainly there's a new book on MI and groups coming out very soon. So these adaptations, these skills can be brought into a group context as well. And so what they would do is, in terms of setting the agenda with the parents that are coming, it might be a larger topic, and then they bring it down and figure out what are some of the key areas for that group that night. And how will you remind yourself to ask permission before providing advice? This is a very important one. How will you remind yourself? So I just briefly wanted to mention, as I finish up here, a couple of resources. I mean, there's so much incredible work that's being done provincially, nationally, on FASD and FASD prevention. So just highlighting a couple of the pieces that we have in BC, and a lot of the work that's done at the Center of Excellence for Women's Health. And my colleague Nancy Poole leads much of this. She's done tremendous work across Canada. And so this website here, the Coalescing website, has a number of different resources looking at different topics. So FASD prevention, there's information sheets, discussion guides, a lot of resources there. This is from a series of discussion guides that we worked on. So this is one example, Mothering and Substance Use, Approaches to Prevention, Harm Reduction, and Treatment. And these resources can be downloaded from the Coalescing site. And the purpose of putting these together was to really capture the highlights from across Canada, what's happening, the guiding frameworks, as well as at the end of it, there are discussion questions. So the hope would be is that it's more of an interactive document, that there's questions at the back to take to policy meetings if you're working in research, or to have conversations, communities of practice within your service, within your community, knowing that these sorts of resources exist to support you in those conversations. There's another quick reference sheet that's been posted on the Healthy Choices in Pregnancy website. The link is there, and it's 10 key resources on FASD prevention. So I've just pulled out one of the more recent ones that you may or may not be familiar with, is the Addiction Toolkit for Primary Care Providers, published by the Center for Addiction and Mental Health. So that's one newer resource that's out there. And this is the other resource that I was mentioning from AWARE in Ontario. It's a resource for smoking. However, a lot of it can be applied just overall in terms of work with women in high-risk situations and across the continuum of risk. Really nice resource that they've done. It's called The First Approach. It's an FASD-informed reduced smoking techniques for service providers working with women who may be FASD affected. And that can be downloaded from their website. And in terms of further resources for your learning, if you're interested on motivational interviewing, I've already mentioned this new book on motivational interviewing with adolescents and young adults. It's from this year. There is a new book on MI and social work coming out. I have a submission in that looking at multi-level training and some work that my colleague Francis Desher and I did in Annapolis Valley Health in Nova Scotia and looked at creating communities of practice and my communities of practice there. And this is another, for those of you that want to continue with skill development, an excellent practitioner workbook by David Rosengren. So final self-reflection questions. What are you already doing that's working to engage women around alcohol and pregnancy? What's staying with you from this presentation? This is where I would ask you to summarize. What else might you add, integrate, or refine in your conversations? Also thinking about how do we share this information? What might be one piece of information that you could share from this presentation with your colleagues, with community members? Why would you choose that piece? What would that look like? And the other really important aspect of doing any of this work is where do you get support? So again, whether you're in a rural community, an urban community, thinking about who are your allies? Who can you have these conversations with? Is it joining a virtual community? Is it connecting with other community members, etc.? This is important and sometimes very challenging work. So tying it up with where we started and noticing if you might do anything different now to the responses. So again, the statements were, now that I'm pregnant and I've been trying to cut down, but it's just so hard when all of my friends drink. So maybe you wrote down what you were going to respond. Maybe you just remember. The hope is that you're seeing now the ambivalence in that statement. That word but is a key indicator. And so being able to recognize and honor that in how you respond and not moving into questions, rather reflecting that. So it's really hard. It's hard to be around your friends when they're drinking. And at the same time, this is an important decision to you and you're doing everything you can to cut down. So I've reflected that back to her. I haven't gone into questions. Second one, I stay away from the hard stuff, which I know is bad for the baby. I just have beer coolers every once in a while. So noticing what you might have responded as we started, the writing reflex may have popped up and you may have been reaching for the pamphlet. And so hoping that you would imagine a different response to this time. Recognizing what she's already doing. You're already taking some steps. Okay? And I just want to finish. I had mentioned the Native American manual a couple of times. This is the reference for it. You can find it online if you just Google Native American motivational interviewing. And so I just want to finish with this and ask you to really listen for what you hear as we talked about the guiding principles, the essence of this work, what you hear in this prayer. Guide me to be a patient companion, to listen with a heart as open as the sky. Grant me vision to see through her eyes and eager ears to hear her story. Create a safe place and open meadow in which we may walk together. Make me a clear pool in which she may reflect. Guide me to find in her your beauty and wisdom, knowing your desire for her to be in harmony, healthy, loving, and strong. Let me honor and respect her choosing of her own path and bless her to walk it freely. May I know once again that although she and I are different, yet there is a peaceful place where we are one. So the essence of this work. That's it. Thank you. Are there any other comments or questions?
Christine, there are no further questions.
Okay. Any comments?
Actually, there were some really excellent comments across Canada about your presentation.
Good to hear, because I'm not getting a lot of feedback here.
Excellent comments from the room.
Oh, thank you. Thank you.
Fantastic. So I'm going to do the closing.
Okay, perfect.
All right. On behalf of the FASD Cross Ministry Committee in Alberta, Christine, thank you for this excellent presentation. It was very informative. I really appreciate the respectful conversation and the use of MI techniques. Really, your presentation could be renamed Conversations with Women About Alcohol and Pregnancy. It was absolutely fabulous, and I'm sure people will take the learning today and the knowledge to heart and put it into their practice. In terms of the clip, we will post it on the website. In terms of the handouts, we will post it on the Research Center's website as well as the Cross Ministry website. There were a lot of excellent comments. We realized that we had to turn the volume up, and so all that has been taken care of. Just note that evaluations will be emailed to all 450 participants today. That is fantastic. Your feedback is critical to our work in Alberta, and we want this initiative to continue through the duration of the 10-year plan and beyond if we can. The next session is scheduled for October 26th at 9 a.m. And Teresa O'Riordan, who is the network coordinator for the Northwest Central in Alberta, will be providing a presentation on safety planning for the service provider. Have a great day, everybody. Thank you so much for joining in. Bye-bye.